Hello, everyone. I'm going to continue to monitor the waiting room so I don't forget anyone, but we're going to go ahead and get started. I really appreciate everyone joining us at 5 p.m. in the afternoon Eastern Standard Time, but very, very early for our speakers this morning. And just really appreciate we're across the continent and very excited to share this Grand Round. So just as a recap and orientation, it's our February Ability Grand Rounds for the Center for Excellence in Disabilities Grand Round Series. This is an international series, and just to get us started, quick reminder about closed captioning. It is available. There's a chat function as well. Please feel free to use that. We're going to monitor the chat along the way. Our speakers will take a look at that. And then we'll make sure that we save some time at the end for any questions. But closed captioning and some other pieces, please utilize that as needed. And then just real quick, be sure to mute your line unless you're asking a question. Feel free to use the raise hand or thumbs up, whichever you feel more comfortable doing, to let us know that you have something on your mind. While we are bringing people in from the waiting room, if you can add your name and affiliation. We were just talking about how we'd love to know backgrounds of people attending. This also helps us gauge the discussion along the way. It's very helpful to make sure that this is connected to what each of you do as much as we can. Use your camera. It's more personal. We like to see your faces. We understand that life, you're multitasking. We don't want you to, be in jeopardy or in safety issues and open your camera while you're driving or anything like that. But if you're okay, please use your camera. We'd love to see you. And again, chat or raise your hand along the way. I'll come back to this at the end if we have time. This as a QR code. You can use your phone to take a picture of this, and that links you directly to the evaluation link. We'd love to hear your feedback, not only on this presentation. The information is shared anonymously from your thoughts, but shared with our presenters, but also the platform in large. Is this helpful? Is this useful? Did you connect with others during this time? Or how can it be strengthened? That's very important to us. So with that, I'm going to stop sharing and I'm going to turn it over to our speaker.
Wow, that was all over the ground.
Hello, everybody. I'm Sally Robinson from Flinders University, and I'm here with Melissa O'Donnell, my colleague and co-presenter. We're so pleased to be here speaking with you today. I'm going to share my screen so that we can start our presentation for you. Just before we get started, though, I do want to emphasize that we really feel that we're talking here to peers. So as Leslie said, if something that we raise for you sparks not only a question, but something that you want to share from your experience, we're really interested to hear. It's a fantastic opportunity for us to talk to colleagues in another country. So we were very excited at the invitation and very pleased to take up the opportunity. So we're really looking forward to seeing how our research project resonates with you in your context. Leslie said that there are people coming today with a wide range of experiences, from people who are new to the field through to people who have more practice experience than we do. So I hope we're not going to teach you how to suck an egg, but I hope that we offer something, particularly from the experience of the young people themselves, that resonates with you. What we're going to talk to you about today is really something that tries to locate children and young people with disability in the context of their experience of domestic and family violence. In one sense, of course, children and young people with disability are everywhere, as they should be, but the barriers that they have are manifold, and I'm sure that people who've got experience in the field are very familiar with this. The reason that we came into this research in particular was a concern that we had about the fact that children and young people with disability live in the intersections much more than other children do. The intersections between different kinds of policy, the intersections between different practice fields, and in day-to-day life, they live in the intersections of the way that policy and practice butt together. And that creates a really complex set of dynamics that children have to navigate and their families have to navigate. And one of the results of that is it makes it really hard for people to see the child first, the young person first. And when life is difficult for one reason or another, it's even more the case that you can see the child in the set of dynamics that is surrounding them. And so that led us to the interest in this particular project. So today we're going to talk to you about domestic and family violence as an example of when this is really happening in young people's lives. And to talk to you about a project called Connecting the Dots, which was about understanding the domestic and family violence experiences of children and young people with disability within and across sectors. You can see on the slide there that this was a big team of people across 3 universities in Australia. So Flinders University, the Centre for Child Protection Studies at the University of South Australia, where Melissa's based, and the University of Sydney Centre for Social Policy was also involved. We were really delighted that this was a co-produced project, and we had Jala Burton involved as a young person with disability as well, who was part of the project from the start to the finish, and continues to be involved in writing the outputs from the project. There's a QR code here. I don't know why, but my QR codes all get produced with a little dinosaur in the middle. And I'm very pleased that they do. I don't know how to stop it, but I don't really want to. The QR code takes you here to the research outputs, and there's a picture of the final report there. So I'll just give you a moment if you want to take a picture of the QR code there to have a look at all of the final reports. There's a report on the phase 1 of the research, which is all of the quantitative analysis that Mel's going to talk about in a minute, a final report that brings together all of the findings, and a practice framework that's aimed at practitioners, and a summary report that Jala led us on, which is aimed at young people and families in particular. So I'll just quickly go over some background. I'm being very conscious that there are people who are very much aware of this in the audience today. So we know that children and young people with disability are a priority group, but there's very little evidence about children and young people's experiences of domestic and family violence across life areas. We do know that children and young people with disability enter multiple systems when there are crises about violence at home. But unless they come in through disability systems, services are likely to have disability front of mind when this is happening in their lives. We know that collaborative responses within sectors and across sectors need improvement. But understanding where and how children and young people with disability feature in large data sets is something that's going to improve knowledge. And in the Australian context, that's a real evidence gap for us. Together with that evidence gap about how children and young people with disability feature at a population level, we thought there was a real need to learn from children and the people who support them to help make policy more responsive to children's own priorities when they experience domestic and family violence. So because of that, we set out to ask what was known about the nature and extent of the experience of domestic and family violence by children and young people with disability, and alongside that, how children and young people with disability who have this experience and their families experience support from service, and how well that support meets their needs. And this was a 3-phase project. The first phase was a data linkage and analysis project, which Melissa's going to talk about in a moment. And then standing on the shoulders really of that research, we did qualitative research with young people and families and providers. And then we brought all of that together in a 3rd phase, which was about generating collaborative priorities with key stakeholders to try and make policy more responsive to young people's priorities. So I'm going to turn to you now, Mel, to talk us through phase 1. Thanks.
Great, thanks, Sally. So yeah, in phase 1, as Sally was saying, we really wanted to understand and scope and map the current data capture of children and young people with disability who experience family domestic violence, and really identify the gaps and limitations, as well as mapping new intersections with the data that are unique to this population. In WA, in Western Australia, we're very lucky to have very large population level administrative data. And we also did a case file review in South Australia to get a better understanding of the nature and extent of family and domestic violence for children and young people with disability. Sally, can I ask you to go to the next one, please? So I guess our first challenge was really defining and identifying disability in the data sets. As you probably know, in the disability sector, disability can be defined in many ways, and there's no real consensus of how we could define that. However, there are existing models of disability. So, you know, the medical model uses very much a diagnostic focused definition of disability, but there's also social and human rights models, and particularly where young people themselves identify their disability and self-identify that. In Australia, we do have the Commonwealth Disability Discrimination Act, which talks about total or partial loss of person's bodily or mental function or parts of their body, or presence of an organism that causes disease or illness, also disfigurement or malformations, as well as those that learn differently. We also have one that looks at illness and disability in regards to person's thought processes, perceptions of reality, emotions, and judgment that might result in behavioural challenges. So we also have a national disability insurance scheme. So they utilise the diagnostic condition, so using much more of a medical model, but they also assess functional impairment as a requirement for the National Disability Insurance Scheme. Next slide, Sally. However, it's quite challenging in terms of linked data, because we have a variety of data sets that we can utilise to identify disability. So we have birth registration information and midwives notifications, and we have hospital morbidity data, and we also have a mental health information system. In WA, we're lucky, we also have a register of developmental anomalies, so children who are diagnosed before the age of 6 with a developmental anomaly. And we also have a specific database that looks at intellectual disability as well and identifies them not only through the West Australian Register of Developmental Anomalies, but also in regards to children who identify at school who are and are assessed as having an intellectual disability and meet that criteria. And unfortunately, that data really much focuses on a medical model, which is very restrictive in that definition, but it's very hard in the linked data sets, and we don't have functional impairment to really assess the level of functional impairment for the children either. In regards to family and domestic violence, we do have a number of databases that we can utilise. So we've got child protection data where families are notified, have maltreatment notifications, or they have substantiated maltreatment, or they enter out of home care. So we've got that data, as well as police domestic violence charges, where a victim, such as a mother, is identified in the data sets, and we're able to identify the perpetrator as a current or ex-partner. And we've also got the hospital morbidity data in relation to hospitalisations for assault for mothers. So from using all of that data, we were then able to identify the family and domestic violence that children may have experienced. Next slide, Sally. So in regards to disability groups, of the children that in our cohort who were born from 1990 to 2009, we had 16% were identified as having a disability. We had a slightly higher proportion of Aboriginal children identified as having a disability, and Aboriginal children did have a higher prevalence of intellectual disability, mental health disorders, spinal cord or brain injury, and asthma. And this isn't just regular asthma. This would be asthma that is hospitalised, so much more severe asthma. Next slide, Sally. And it's really interesting. We're trying to understand also that, you know, often children and young people with disability may have multiple disorders across different areas. So we tried to get an understanding of that by grouping them in chronic health conditions, mental health conditions, intellectual and developmental conditions, and physical conditions. And 83% of the children we identified only had one of those conditions. However, more than one was about 17%, and the most prevalent coexisting conditions were mental health and physical conditions at 4.5%, as well as physical and chronic health conditions at 3%. and physical and intellectual and developmental conditions at 2.5%. So you can see here there are a large proportion of young people who would have more than one condition that we identified in the data. Sally, next slide, thanks. So in regards to domestic violence exposure, so that's where mothers are hospitalised for assault, we found that there were 22,368 children who had a mother hospitalised with assault over that period. So in the population cohort, that's around 4% of children were exposed, had an experience of a mother with a hospitalisation for assault. But for children with disability, it was higher at 8%. So when we look at those children who had a mother hospitalised with assault, what we did find was 29% of those were a child with a disability. So we're looking at quite a large proportion of that group. Next slide, Sally. We tried to get an understanding of what disability groups are most affected by that. So most disability groups had a higher proportion exposed to a maternal hospitalisation of assault across all of the disability groups, and that orange line there is basically the general population of those who were exposed. But the highest groups that were exposed were those with a mental health condition, and 13% of children diagnosed with a mental health disorder and conduct disorder as well as intellectual disability. So you can see there it's quite high proportions in those groups, but overall it was greater. The other group that was high was also children with epilepsy as well, so those chronic health conditions. So that gives an understanding of, I guess, there's a lot of complexity in the cases of families in which a mother's been hospitalised with assault and the range of needs that those children in those families do have. The next slide, Sally. We also looked at child protection involvement. And as you can see, for each of the areas of child protection involvement, the children with disability had over 2 to 3 times higher proportion. So you can see there that of those children who have an allegation, we've got 11.2% in the population were children with disabilities, compared to 5.5% in the general population. And as you can see, that's very consistent across the groups. So when you get to out-of-home care, in the general populations, it's 1.7%, but for children with disability, it's 3.9%. So when we look at that group that child protection services are involved in, you're looking at about 31% of those children, of those with an allegation having child protection, having a child or young person with a disability, and that's pretty much consistent in terms of 25% of children in out-of-home care having a disability. This shows really the complexity of needs that the child protection system has to face in terms of providing services and support for those children and young people. And I think that's a really important message in terms of the needs of children in out-of-home care and the complexity of those needs that need to be met, particularly in regards to health and mental health issues. Next slide, Sally. We tried again to look at the overrepresentation across different groups of disabilities. And you can see here, again, it was highest for conduct disorder and ADHD, conditions resulting from physical impairment and intellectual disability. But overall, you can see that it's much higher than the general population in terms of child maltreatment allegations and that overrepresentation. Next slide, Sally. We also tried to understand the complexity of issues, so the overlap with maternal hospitalisations and child protection involvement. So you can see here for children without disability, it was about 34%, but it was even higher for children with disability at 47%. So if a mother was hospitalised for assault, they were also involved in child protection involvement. So there's a real complexity of systems that are involved with these children. Next slide, Sally. We then looked at the police FDV data, and obviously, we're really touching the extreme points of intervention for families with with experiencing family and domestic violence, because as you know, a lot of families don't end up going to the police or are hospitalised for assault. But even in the police data, we did say that children with disabilities were over-identified. So there was 30% of mothers who were identified in the police FDV data. And what was a real concern for us was, while we expected probably that when the police are involved, often child protection services become involved with families. Again, it was much higher for children with disability. So this is where police are called out to an FDV situation, and then the children are also involved in child protection services data. So you can see there for children with disability, it was an allegation was 66%, substantiated allegations 36%, and entry into out of home care was 22%. Next slide, Sally. To really understand then the nature of the family and domestic violence that's being experienced by children with disabilities, we did a case file review using child protection data. So there was a sample of families selected. That was 280 of those families that were reported to child protection between July and December in 2016. So 22% of those families included a child with disability. And so for 73% of those families, they did have exposure to domestic and family violence. And for many of the families that in the case file review, the domestic and family violence was chronic. So it wasn't just a single incident. There was often many incidents over time in which they experienced that. Next one, Sally. In terms of the themes that really came out from the case file review, were that the first one was that children with disability experienced trauma as a result of domestic and family violence. So in the case files, it was stated that the children were scared, distressed, anxious, and were having behavioural problems in response to domestic and family violence. The theme too was around the perpetrator of the domestic and family violence directing violence towards the children with a disability. So it wasn't only that and other family members were affected, such as the mother, by the domestic and family violence. There was also violence directed towards the children. Also, what emerged was that the violence negatively impacted on their service access for children with disabilities. So there were statements that services did not feel safe to deliver services in the family home. So this really impacted then on the service provision for those children. Next one, Sally. There was also incidences of where intervention order breaches occurred. So where a mother had a violence restraining order against a partner, there were cases in which the mother needed support for parenting for their child with disability, and so had reached out to the ex-partner to look after the children for a period of time. And this was the concern, I guess, when child protection are involved, because they're monitoring that involvement with the perpetrator. But this also points to the issues around the need for support for families who are going through domestic violence situations and the extra needs that their children would have, and the reliance then on a support network to provide that support. The other theme that emerged was there were the disabilities of children that presented added complexity to escaping family and domestic violence. There were statements in the case files that the mothers couldn't use certain refuges or other safe houses because they required disability access for their children, or that in a refuge situation where a child with autism would have difficulty in a new environment and having to deal with either the safe houses that were offered or the refuges. So that is another consideration in terms of the support that's needed for those families, particularly mothers who are trying to escape domestic violence, but their children have extra needs that need to be taken into account. Okay, last slide for me is, what did we learn through this phase? I guess bringing together and analysing the large data sets, we could try to see where children with disability were present. And as well as analysing those reports, gave us a little bit more understanding of the nature of that exposure as well. So as you can see, children with disability who experience family and domestic violence are present across all of those systems, so police, mothers' hospitalisations for assault, as well as child protection involvement. They have double the exposure to domestic and family violence to children without disability, as we measured through the mothers' hospitalisations for assault. And they make up approximately 30% of children exposed to domestic violence, according to the police and hospitalisation data. They're also far more likely to have child protection involvement and entry into out-of-home care. So they made up approximately 32% of children involved in child protection and the 36% of children involved in out-of-home care. And we did note that Aboriginal children with disability were more likely to be exposed, as well as children with disability in regional and remote areas. And they were definitely more overrepresented in our sample. It's interesting that in the case file reviews, they did show signs of trauma as a result of the domestic and family violence. So it wasn't just that they may have witnessed it, etc., but often they were also directly experiencing that violence themselves. And it also negatively affected their access to services. And it was also harder for those families to leave domestic and family violence situations because of a lack of safe and accessible housing that also took into account their children's needs. So I'll now hand over to Sally, who will continue with the presentation. Thank you.
Thank you very much, Mel. I'm sure you'll all agree that the first phase of the research was incredibly important just on its own, but it also gave us something really important to stand on the shoulders of, because it meant that we didn't need to ask children or families about these experiences directly. It meant that we could move on to talk to children and young people about what had helped in the context of these experiences that they'd had. So in the next phase, we did interviews with children and young people with disability, with families and with practitioners. And this was obviously a complex context. Mel's painted a very clear picture of just how complex the context was in which these interviews took place. We don't have time to really talk you through the methods that we used, but they're described in the report and in an academic paper that we wrote, which you can find on the website that I showed you earlier. There's a couple of pictures in here that just give you a sense of some of the methods that we used with the children and young people, though, including this beautiful picture by Isaac, where the kids talked about how they saw themselves and some of the things that were important to them. It's worth pointing out, though, that some of the young people were not able to contribute directly to the study. And sometimes that was because their parents felt that they were too traumatized to participate directly. Sometimes it was because of high and complex needs. Sometimes it was because they'd been removed from their parents' care. There was a whole range of reasons why we couldn't speak directly to some young people. And so the experiences of 36 children and young people are in the qualitative research, but we were only able to speak directly with 12 children and young people. So we found out in talking with children and young people and with people who are close to them that there was a really different picture about the way that children were understood. They were seen as children first, whole people with interests and relationships and humour and a sense of fun, who were valued and loved for who they were. And that was so important for people to portray to us. It was very important for people to show that they were in a network of relationships, and that home and family life was so important to children and young people, and also to their families, mostly their mums who spoke with us. Most of the children lived with their families, apart from a few who'd been removed into care, but they had complex and sometimes tension-filled family relationships. Children talked about feeling safe and not safe, and the things that helped them were safe adults in close circles. But they also talked about a lot of tensions about stress and anxiety in daily life. And sometimes some of the young people and children talked about difficulties in friendships and interpersonal relationships that worried them, and how that was a diffuse concern that played across their daily lives, and their experiences of domestic and family violence can't be divorced from those things. So the experience of domestic and family violence that we were able to extract from the interviews with people, although we didn't directly ask them about domestic and family violence, was about how this affected their sense of voice and agency. The fact that children and young people took in a lot more than the people around them realised about the experience that had happened to their family and to them. that it was hard for children and young people to have their perspectives and priorities heard, especially for children and young people who had high support needs and people who had alternative modes of communication. People talked about domestic and family violence that they remembered, especially violence that had disrupted their family life. They talked about moving house, about conflict around negotiating their needs, being removed from their family, going to school far away from the home that they used to live in. And they talked about feelings of being scared and anxious about change and about different places and how that affected them. So you can see a quote there where I'd been in conversation with a girl who, for the purposes of anonymity, is called Jessie in this quote. I say, do you worry a lot? And Jessie says, yes, you know, the tiniest things I worry about them. And I said, what helps you to stop worrying? And Jessie said, not really anything. I just wait until I stop worrying. So the effect of domestic and family violence on young people's sense of security was quite striking. The violence was destabilizing and dislocating. And in some families, the current conflicts that they had with siblings had a similar pattern to some of the violence that had played out with ex-partners who were perpetrators of domestic violence. So the trauma that was caused by domestic and family violence was seen in children in some cases because in their direct experience of domestic and family violence, but also the ongoing psychological effects of violence. Some of them had been diagnosed with anxiety and post-traumatic stress disorder, conduct disorders, behaviour disorders, but there were also a lot of related kinds of behaviour that parents described that had not received any kind of formal diagnosis, which mattered because people weren't getting support for that kind of those kind of effects on children. Some parents stayed longer than they wanted or was safe, or they returned to violent situations because of a lack of alternatives, which supports what Mel had found in the earlier phase of the research. And people also talked about intergenerational and collective trauma. And then social isolation following domestic and family violence was also very striking. The kind of support that was provided to children and young people and their families who were facing domestic and family violence kind of clustered into three sorts of supports. There were family-focused supports around housing and material support, counselling, referral to either justice-related agencies or disability-related and funding-related agencies. There was child and youth-focused support through school, children's workers, community workers, youth crisis services, psychology, and health services. And then there was disability-related support. The National Disability Insurance Scheme in Australia is the dominant framework through which disability support is provided. And it's the sort of the eye of the needle through which all support has to be provided now. So all of the supports for behaviour support, counselling, therapies, daily supports, assessments, and the coordination of all of those sorts of things went through the NDIS funded portal. And then there was also some services around substitute decision making through the public guardian mechanism as well. So there was a big range of supports, and that big range was important because there was a lot of negotiation and a lot of coordination of all of that different kind of support. And then thinking about how well all of that support met people's needs was really interesting. So there was the effect of limited child-focused practice could really be seen. There was some child-focused practice, and it helped. But practice that disregarded children's experience was not challenged in any kind of systematic way. And that meant that children, that practitioners who ignored children, who didn't have child-focused practice as part of their regular framework of practice, were not were not challenged. And so it was very easy for practitioners to say, well, that's not part of my skill set, and for it not to be picked up and not to be challenged. So it was very easy for children to be overlooked in practice. Relationship with trusted practitioners was a core thing that people talked about as helpful, but the quality of individual practitioners was experienced as more effective than systems kind of responses. And sometimes people were good despite the systems that they worked in, not because of the systems that they worked in. And so really, when systems are weak and individual people look away then from domestic and family violence and an abusive experience, then that can leave children in abusive or dangerous situations. So relying on a good individual was good in the moment, but dangerous as something for us to rely on over time. Children and young people felt that it was very helpful when they were seen as people who had agency, who were seen as having the opportunity to express themselves and be heard. And when people practitioners saw the whole person, it really facilitated good practice. Being able to see the child as distinct from their mother or their family mattered. And some practitioners could see that and some could not. And especially for children with high support needs, it was less common for practitioners to be able to see the child as distinct from their family. And a lot of services are not resourced to see that, and policy doesn't support them to see that as well. In Australia, domestic and family violences take a family first approach, with the sort of idea that if you support the mother to recover and to feel strong and to be able to support their family, then the children are going to benefit from that. And of course they do, but it's not sufficient to also meet the needs of the child at the same time. Trauma-informed and disability-informed practice sometimes was seen in individual practice, but not embedded into policy and practice at a systems level. And there was a lack of understanding of what trauma-informed practice meant in intersection with disability and domestic violence and age for children with disability. And people really needed those three skill sets together: disability, violence, and age-related skill sets. And then prioritising resources and resource management and crisis management for families didn't really equate to trauma-informed support for children and young people. The flexibility to use support in ways that suited children and suited them in their family context really helped. Having variable communication in systems across sectors to meet children's interest was another thing that helped. Changing your communication style to suit children and having the skills to support that. And then the family first approach to practice frameworks I mentioned. So I'll just keep moving because we've got a lot to get through. I'll just talk about a couple of quotes here that really exemplify, I think, that people had different approaches to talking about the same kind of problem. So these are pseudonyms. Lee, who was 12, aged between 12 and 16, pointed out that the main thing we need is my mum needs financial support. I do feel like more could be done because my mum's having trouble with funding for disability-related support. And then Tracy, who was Lee's mother, said, I've had to be very strategic with our funding goals, not to mention trauma or disability. It's just, this is my goal for my son, and then that becomes his funded goal. So I don't say he's got these behaviours because of trauma. It's these are the behaviours he displays. This is my goals for this year. I changed it to that. But now I'm finding there's a 2-year waiting list for children's therapy service. And this was in the context of them having been knocked back twice for trauma-related therapy for her children who had extreme trauma-related behaviour problems from the experiences that their family had been through. And then a practitioner whose window into the issue was, I think there's multiple issues there around the complexity, the number of rules, the amount of time it takes, and the amount of evidence that you need. So they all have different perspectives on the same issue. So turning to what might improve support for children and young people in this position. At a practice level, the planned, thoughtful ways for children and young people's ideas and priorities to be heard and to be responded in the services that they use was a priority for children and young people and for families. Finding safe places and safe people to listen to what's important for children and young people, to be able to respond to that, obviously, is an underpinning for that. Responses that understand and acknowledge how disability is interwoven with trauma for children and young people with significant support needs is really important because one of the things that we saw in this Australian context was a divorcing of trauma and behaviour. And of course, they're so interwoven. Improving support to families when they're in crisis was something that was really evidently needed because the expectations on families to navigate very complex service systems was really unrealistic. Seeing children and young people both in their family context and as individuals with complex trauma was something that really could have been improved in the context that we saw. And then delinking funding for children from their family's capacity to apply for it would have really improved the situation of lots of the children in our study because the mums were not in a position to go through these complicated funding applications because they were doing a fantastic job just getting through the day-to-day in the circumstances they were in. They were not in a position to go and apply for to go through multiple assessment processes, to go through complicated funding applications, to go and put themselves on multiple waiting lists for multiple services, which is what's required in the National Disability Insurance Scheme context. So we really need proactive cross-sector funding and supports at an early point, especially in places like first responders, such as hospitals. We can see from the first phase of our study that places like hospitals, paramedics, police, are going to be seeing lots of children with disability in families. Everybody in those first responding services should be expecting to see children with disability and young people with disability and have responses at the ready to be able to support those children and families and to be able to refer them into places that are going to meet their needs. And then, of course, the need for skilled support and therapeutic responses for recovery from domestic and family violence, which in Australia is very much lacking. I hope you're going to tell me there's a better picture where you are, but I'm not optimistic. And then there are implications for policy, which I won't belabor here because it's the Australian context, but there is really urgent policy attention to set up the mechanisms for these things to flow. And in Australia at the moment, this study sits in the intersection of a national policy change. But I do just want to point to it because I think it's relevant in an international context as well, that the needs that need to be met need to happen in an integrated way around disability, children and violence in order for change to really come to pass that's going to make meaningful change in this space. I do just want to point to the fact that children and young people with disability were clear about what mattered to them when we spoke to them, and their priorities weren't well responded to by systems and services. And as a result, lots of children were falling in gaps between service systems. And their experience was that they met practitioners who didn't have the three skill sets that I mentioned before: trauma-informed practice, disability-informed practice, and child-centered practice. And they really needed those three skill sets. One thing that was really heartening is that all of the practitioners we met wanted more. They had more expectations, higher expectations for children and young people with disability to have better lives, and everybody wanted a reliable level of high quality. And one of the things that came out of that that expectation and that want that everybody had was the desire for a practice framework that provided more practical strategies. And so we responded to that, that sort of enthusiasm by developing a practice framework out of the research. And there's the link with my little dinosaur again to the practice framework, which uses 6 key principles that came out of the research and a whole lot of strategies which were from practitioners and from young people and families to identify practical things that people can do to generate change in their own particular sector environments, but also in their own daily practice. We were really indebted to Jala, our community researcher, for pushing us to develop a section in each part of the practice framework that are things you can do today. So down the side of each section of the framework, there is things in your practice that you can do that don't require any resources and don't require anything apart from really attitudinal change, that are things people can pick up on straight away. So really in closing, the so what that this study tells us is that there's a high proportion of children and young people with disability who are exposed to domestic and family violence and involved with child protection. There's variability among children with different types of disability to that exposure. But the children and families who experience domestic and family violence face complex challenges, and those challenges are increased for children who have additional support needs. With such a high proportion of children involved in family and domestic violence services or in child protection systems, organisations across all sectors really need to make sure that they're equipped, that they've got the skills and resources to address the additional needs of a significant proportion of children that they meet. And from the experience of children and young people, we know that there's some serious shortfalls in how services respond to children and young people and their families to make sure all children are receiving the support that they're entitled to. And children and young people themselves have few opportunities to have input about what they want to happen in their lives and how they want things to improve. There are a lot of examples about how it's possible to do this ethically and positively and constructively. And practitioners wanted to know a lot about how they could be part of this and to use frameworks to make it a standard experience. And as a case example, I guess this project shows us that children and young people's lives aren't lived in silos, even though our services are provided that way. It's even more evident when difficult things happen in people's lives. Our systems really are much too complex for families to navigate, especially at times of crisis. And collectively, we really need to do a much better job of supporting people across the intersections and not dropping them in the process. Finally, a call from the children and young people to treat them as citizens and not as possessions of adults. Just as we close this part of the conversation and move to discussion, if you'd like to be in conversation with us or to look for any further information, there's the link to the final report and my email address. Melissa or I would welcome any more conversation with you. Thanks very much. Leslie, we might pass back to you now for turning to the next part of the discussion. Thanks.
No, appreciate it very much. So I know that I'm just seeing some of our participants and their affiliations. You had posed the question of, is it any better over here? And so let me turn to anyone who's willing to put their perceptions in the chat or come on camera and give us your perceptions of West Virginia and how we fare compared to what you saw on the slides. Any thoughts on that front? Or separate, any questions about other slides? But I did want to give everyone the chance to address your question to us.
I thought it was fascinating. I would love, and I think it's probably with the dinosaur QR code. I was zooming on my phone, so I wasn't able to scan it yet. But the resources, I would love to have those where the things you could do without any cost resources, I think that you'd mentioned, that sounds fabulous. But I think our experience, at least what I've seen, is that whenever there are protection variables with kiddos that have more complex healthcare needs, that there is a tendency to sort of look the other way in our area. And so just giving the families the resources as much as possible is really helpful. I think that there is that aspect of just how complex it can be because it's so layered with the needs of some of those high risk situations too.
Yeah, thanks, Anastasia. That's really similar to some of the things that the practitioners talk to us about. And one of the things that we developed the framework in consultation with some of the practitioners who were involved in the research. And one of the things that they talked about as really building their confidence were just really small things like having a communication kit in the back of your car that doesn't need to be fancy at all, but has things like drawing materials and artwork things and fidget tools and things that help kids feel comfortable, so that you help you feel prepared to engage in a non pressured way with kids who don't communicate with words. And people talked about something as small as that as building their confidence, because they would have a different way of communicating that wasn't a sort of a question and answer about the experience of domestic and family violence if they didn't have experience in working with children with disability. And to me, I thought that's actually such a small strategy, but people just needed something practical to like, oh, I could just buy a fidget tool at Target and a box of texters and a pad, and that's enough to have a little kit bag. So it was great to, I mean, it's just another endorsement, I suppose, of working in a co-design way, really, isn't it?
And that's really interesting, Sally, because on a very separate note, but related, we've been talking about kits that center-wide, regardless of the program, what items would universally be needed in that kit. And kits are for different, sometimes it's a daily, a personal hygiene kit or something like that. But you're describing a kit for connection, a kit that could be used in that home visit in whatever setting. So that those two things came to mind for me when you were describing that in that way. It's really interesting. I know that others are on here who are caregivers, who support caregivers of children with special health care needs, adolescents, older adults. I'm curious in terms of the quotes that Melissa, you shared, and Sally, you shared later as well, quotes from caregivers about stressors, about experiences. Did those sound similar to what you all hear, whether it's within a domestic violence situation or just in general in terms of the stressors and the funding and how people navigate? I think we have DHHR representation. Oh, there's Tina.
Yeah, a lot of the quotes sounded the same. Fortunately, I've been, sorry, let me silence my phone here. Well, it's not going to let me, but
We can't hear it. It's all good.
Fortunately, I've been lucky enough that I haven't ran into any of the families that I work with having like the domestic violence situations going on. So, I've kind of been blessed in that area. I'm sure as time goes on, there's going to come a time where I am seeing that. But yeah, the stressors and stuff like that, those are the types of things that we do here. So.
It was interesting to hear the trauma-based stressors versus the disability, how they're separate but interacted. And how people, how caregivers start to see it that way too. Thank you, Tina, for that perception. Any other questions? We have about 3 minutes left. I don't want to overlook anyone. All right. Well, with that being said, again, Sally and Melissa, thank you so much for joining us. We really appreciate you connecting with us across the world, basically, and waking up early, sometimes extremely early, right, Melissa, to share your work. And what we'll do, we'll be sure to include the reports that you gave us in the QR codes with the recording. We'll post that on our website for those who weren't able to join us together, and your link to ask you any questions as a follow-up. So thank you very much for that.
You're very welcome. Thanks very much, everyone, for your interest.
Thank you.
Thanks, Leslie.
Thank you. Have a nice evening, morning, whatever it might be. Take
Bye,
care.
everybody.
Bye.